Hello, everybody. This is Brenda Green with the Be Strong Group, and we're so excited to be talking to you again today. Several discussions about, let me mute my phone, and about discussions of topics that are important to those with sickle cell disease. So before we really get started, for those of you who have never seen one of our sessions, I'm Brenda Green with the Be Strong Group. I am a founder and CEO. Along with my husband, we founded this nonprofit in honor of our son, Braden, who has sickle cell disease. And it is our purpose to help spread awareness of sickle cell disease through advocacy, education, and empowerment. And this month, September, is Sickle Cell Awareness Month. And we wanted to do our part to share information to our followers and supporters and other warriors. So we've already spoken to professionals about education, about the importance of mental health, and about blood donation. So today we're so excited to talk to physicians who are advocates for sickle cell disease. And the first one, I'm actually so excited, and I'm gonna try not to be overly excited, but her name is Dr. Carla Roberts, and she is a pediatric hematologist at Prisma Health Children's Hospital here in the Midlands, and we're so excited to talk to her. Dr. Carla is our doctor, and she's Braden's hematologist, and we met her when Braden was 3 months old. So Dr. Carla, thank you so much for joining us. We appreciate you being here.
Thank you for inviting me. I'm excited.
Great. So Dr. Carla, I know my husband and I started this nonprofit, and we kept having, when people ask about Braden, they kept saying, he has sickle cell disease. What is sickle cell disease? And, we pretty much had to explain from our perspective what it is. But since we have you here, can you just, from your perspective, just tell people, tell our followers what sickle cell disease is?
Sure, thanks. So sickle cell disease, it is an inherited hemoglobin disorder, and you have hemoglobin that's inside your red cells to carry oxygen, and you inherit a hemoglobin gene from each parent, kind of like your brown eyes or your hair color. There's normal hemoglobin, but there are hundreds of abnormal hemoglobins out there, and depending on what you may inherit from your mom and from your dad may give you a type of sickle cell disease. And with sickle cell disease, the hemoglobin inside the red cells, it undergoes some conformational changes and makes it all sticky inside the red cell. And then a normal round red cell is then going to go to a sickle shape, kind of like a crescent moon shape. And those sickle cells then can start to kind of clog up the tiny blood vessels, and they also don't last as long as normal red cells do. So they're always breaking down and releasing some substances into the bloodstream that can make you sick as well. But also, a lot of people think of sickle cell disease as a red cell. It is a hemoglobin red cell disorder, but it's much more complicated. We're starting to have a kind of shift and change of it just being about a red cell problem to a whole blood vessel problem. So it's the blood vessels are not always healthy, and the white cells play a role, which usually think of fighting off infection, but they can play a role in sickle cell, as well as the platelets, which you typically think of as causing you to making you make a blood clot, but they also play a role as well. So it's becoming very complicated, and as a result, I think we're just exciting the different treatment options that there may be for the future as we learn more about it.
Right. So what are some complications that can occur from someone with sickle cell disease? And we do know that there are different types of disease.
Mm-hmm. Right. Yes. Yeah. There are different types of sickle cell disease, but the hallmark is the painful crisis. And so with a painful crisis, what can happen is that it's usually in the tiny vessels that are going to you have blood that goes all over your body. So your arms, leg, back, stomach, anywhere. those tiny little vessels that are trying to supply oxygen, carry red cells to supply oxygen to those areas, they can start to become clogged up with the sickle cells and those white cells and the platelets and the blood vessels, and wall is irritated. And therefore, that part of the body won't get any oxygen that it needs, and that part of the body would start hurting. And pain can start at a young age in infants, and go on into adulthood. So that's one of the more common problems for people with sickle cell disease, the one that people kind of hear about the most.
Right. Okay. Now, can you explain what constitutes an emergency when it comes to a child with sickle cell disease?
Right. Well, for a child and an adult also, the spleen, which is kind of like it's in your body, it's kind of like a garbage disposal for your body, helps you get rid of infection, old red cells and things in your body. It doesn't work quite like it's supposed to. So people with sickle cell can be more susceptible to certain bacterial infections. And so fever is an emergency for people with sickle cell disease. And it's actually the reason that we actually have newborn screening for sickle cell disease, because by starting an antibiotic at a young age, by 2 or 3 months of age, that will help prevent some of the serious bacterial infections. But and whenever that was discovered back in the mid 1980s, that's what actually prompted newborn screening for sickle cell disease. So now it's part of all babies, when they're born, they get screened for sickle cell throughout the United States. But because the penicillin doesn't prevent all infections, any fever, that's considered an emergency. Other things that are emergencies for people with sickle cell, if the spleen, like I said, it's not working quite as well, but sometimes it can become really big suddenly, and that's called splenic sequestration. So that blood that's out in your bloodstream can get trapped inside that spleen. So then you don't have as much blood flow circulating in the rest of your body. And people with that can become very anemic quickly. So we teach parents how to feel for their child's spleen and to recognize an acute splenic sequestration crisis and to go to the emergency room should that happen. Another emergency would be a stroke. And it seems this wouldn't be in children, but children with sickle cell can be prone to strokes. And we do screening now to see if people are at risk, but there are some people that that may not get the screening test done, or that may not be picked up. And so any signs or symptoms of a stroke, you need to get to the emergency room.
Right. Now, I know a lot of times I kind of explain to people when they ask me, I say, oh, Braden has a doctor's appointment. And I have to explain to them that, sickle cell can impact every part of his body. Mm-hmm. So we see a lot of specialists. Can you kind of talk on that part, how important it is to make sure, of course, you're along with Dr. Claytor, our pediatrician, are the main mm-hmm. doctor, but can you speak on the other specialists that a child or a person with sickle cell may see as well?
Yeah, so children with sickle cell, they should all, and adults too, should keep up with their primary care provider. But there are other specialists that they need to see. Around 8 or 9, 10 years of age, we recommend to start going to the eye doctor once a year to screen for any sickle cell changes in the eyes. Asthma is more common in children with sickle cell than the general population. So many of our children are also followed by the pulmonologist to get asthma care. We have some of our patients we screen for kidney problems, and whenever we start picking those up, so many of our patients are followed by the kidney specialist to address those issues. And many of our patients too, some of them have where their hip bones have been affected by sickling and can have some deterioration. So those patients are followed by the orthopedic surgeons. So it is a multidisciplinary team that takes care of patients with sickle cell disease.
Right. And I know you heard me earlier, we've already spoken to an educator about mm-hmm. the education piece. We've spoken to someone about the mental health piece because about me with Braden, I want to make sure the whole Braden is okay. Mm-hmm. And there's a lot that comes into play when it talks about that. And we also spoke with the Red Cross talking about the importance of blood donation to people with sickle cell. Can you just speak on that level as far as blood transfusion and exchanges as
Yeah.
a treatment?
Yes, yes, yes. Like you're saying, so it takes a village to raise all of us and we're thankful for that. But as far as the transfusion, so some patients need transfusions periodically, like perhaps for something called acute chest syndrome, which is where the lungs can be affected by sickling and need a transfusion then, or if someone has a stroke, they would need a transfusion, or if they have that severe anemia, like from their spleen getting big, for instance, they would need a transfusion. And then we have some patients that are, and those are episodic, like those may happen in the hospital. And then we have several patients who are on what we call chronic blood transfusions, and they are getting transfused every month or so. Those are our patients who are at risk for stroke or who've actually had a stroke in the past. And the treatment plan for them is to give transfusions again every month or so to try to prevent a stroke from reoccurring or to prevent a first stroke from occurring. And so blood transfusions are incredibly important. Blood donations incredibly important for our patients.
All right, awesome. And can I mention, we did host the blood drive this past Saturday, and we collected 52 units of blood.
That's awesome. Wow. Yes.
So
I'm actually, in the AC Flora parking lot now. I wish I was going to try to stand in front of the AC Flora sign, but it was too noisy out there.
Oh, okay.
I know you were going to have a blood drive here.
Yeah, yeah. So we're excited about that. I'm going to check in because I know your time slot was for the first 15 minutes or so, but can you wait so that we can check in?
Of course. Yes, yeah.
If we have any questions in our social media. And can you add, if you have anything you want to go ahead and add to the discussion?
Sure. Yes. Yeah. Because I know one of the some questions always asked, is there a cure for sickle cell? And yes, there is a cure. That's with a bone marrow or stem cell transplant. But unfortunately, a lot of people with sickle cell may not have a person who's a good match to be a donor for them. So what's exciting right now are the gene therapy trials that are going on for sickle cell. And currently they're in adults and teenagers throughout the United States. And they started the trials in Europe before here, but we have some exciting preliminary results. And Bluebird Bio is one of the companies that is sponsoring these gene therapy trials. They've again had some exciting results, and anticipate sometime later in 2021 perhaps opening up gene therapy for more people. It's very exciting. Oh,
absolutely. I do get messages and email about that as well. People who care for us and care for Braden. So I could just see, this cure, and maybe Braden can get it. And I kind of explained, and I'm hoping I explained it the right way, is that right now Braden isn't a candidate for current cures right now, but we're hopeful.
Yes.
But until then, we're going to manage it well.
Right. Now as he does. And in the meantime, for some patients that may be candidates for transplant or for gene therapy, who just can't get that done for whatever reason right now, hydroxyurea is an excellent drug that is used for sickle cell, and it's actually become, for people with the more severe type of sickle cell, it's now standard of care. Okay. And we're have seen lots of very positive changes with that medication, preventing some of these crises, preventing strokes, preventing the kidney problems, keeping the lungs healthy, etc. Right,
and there are several new medications as well that has come to fruition, which is good.
Yes, so finally, yes, sickle cell is getting the much deserved attention. It is finally coming, and from the National Institutes of Health, from the CDC, from drug companies now, people are on board and are specifically looking for drugs and creating drugs that are just for people with sickle cell disease. So it's pretty exciting.
It is. I know I asked a question of our board of director, one of our board of directors, Angela Mack. Angela, do we have any questions for Dr. Carla?
Yeah, there was one question about, are there any things that the sickle cell warriors or their parents can do from home as far as like preventive things like maintenance or things that they should be doing on a regular basis to kind of like prevent a crisis?
Yes. Well, you'll hear me harp all the time, water, water, water. And so stay hydrated, because if you become dehydrated, some of the water that's normally inside your red cell is going to come out and get from the red cell and go into the bloodstream. And that's going to be a trigger to make that cell go from the round red shape to the sickle shape. So hydration is super important, and we recommend water because things like Gatorade and things have a lot of salt in them, and that can actually pull water out of the cell. And so we recommend water for that reason. Gatorade every once in a while, that's okay, but water, water, water. And whenever we're at camp, in the summertime with children, we have water stations everywhere, and really, focus on that. We also focus on trying to stay warm and like avoid cold temperatures. So always, taking a jacket with you to places. Don't swim in cold water. These are all things too that we learn at camp. At camp, we try to focus on how to, live healthy, and so trying to avoid cold temperatures is another mainstay. And then I think too, we advise against really competitive sports and things that are really strenuous, but some exercise is good. And so trying to walk some and be outside, trying to eat healthy as possible. There are foods that are made rich in antioxidants. People often ask if there's a certain diet that they should eat, and there are not a lot of validated studies, but I think just good in general, good healthy diet, fresh fruits, vegetables, antioxidants. Because one of the new medications actually that was approved a couple of years ago works by way of being an antioxidant. Okay. And so if you can enhance that in your food, that would be a natural way to do that.
Oh, awesome. And we have Miss Anna with DHEC that's going to talk to us next about nutrition. So
good.
That's an important part of it, piece of the program as well. I know we're running over time, but
that's okay. If Dr. Cheedy is, I'm not sure if he's on or not, but if not, I'm happy to keep going.
Dr. Cheedy is on.
Okay.
But Angela, is there any other questions? I finally was able to mute my phone. We love Dr. Carla, and we do. I see a lot of those in the comments. So that's
you make what I do very easy. This is not work. This is my passion.
And that's what we love to hear. And that's such a blessing, because that doesn't occur everywhere in our country, So you just have to know how valuable you are and important you are, at least to our family, and helping us along this journey and making it, tolerable, tolerable, and educating us along the way. And I'm so glad that you took time out of your busy schedule and family life to speak with us this evening. So, but Angela, did we have any other questions? Otherwise, we can.
No, Dr. Carla answered the second part of their question about exercise and nutrition. So that was good. So it was like a multi-level question. So we're good. Okay. Thank you.
Thank you, guys.
Thank you, Dr. Carla. If you want to hang on, you can. But
okay. Yeah, listen. I know. I will hang on a little bit.
We're excited also to have Dr. Cheedy Jaja, and he's an associate professor in the College of Nursing at the University of South Carolina. We're so excited to have him, and he has over a decades of experience providing clinical and psychosocial care to patients with sickle cell disease. He also mentioned that this is his passion, and he can talk to you and elaborate more on his credentials, but his research interests are sickle cell disease and pharmacogenetics and healthcare disparities. And we're so excited to have Dr. Cheedy on the call, and he's going to be talking about some interesting thing. And I know Dr. Carla mentioned about pain being one of the the most problematic, could be the most problematic issue when it comes to sickle cell disease. So Dr. Cheedy, I'm going to let you take it on over because, you know, we want to hear what you have to say.
Can you share your screen? Because I have a presentation, if that's okay with you.
You want me to share my screen or?
Yeah,
can we post? Okay, hold on. Let me do that. All right.
See my screen?
I can.
Okay, so I am going to talk about pharmacogenetics in sickle cell disease pain management. And that really is my passion. And Dr. Carla has been very, very generous with the time, but also in actually setting the background for what I want to talk about. And basically, I want your listeners to know that we are really going through a very exciting time, you know, in terms of sickle cell research, in terms of new innovation in patient care. And pharmacogenetics is just one of those exciting areas in medicine that is really going to bring or make a difference in the life, you know, of our patients. So I'm glad that I have this opportunity to talk to your audience and really to share this field and to really show, you know, that that's, like I said, we're really going to a very, you know, interesting moment in terms of the tools, the resources that we now have to make a difference in the lives of patients with sickle cell disease.
Right.
So typically, the idea is that what causes sickle cell pain is when we have those hemoglobin clumping up in those small micro blood vessels, and they kind of like occlude the blood, meaning that they stop the blood from flowing properly, and that's what causes the pain. But as Dr. Carla mentioned earlier, that's not quite the entire picture. There's more to that. And that's where pharmacogenetics, what I'm going to talk about, comes in. Okay.
Okay.
Part of what we know is that patients with sickle cell disease, even when they're not in crisis, pain crisis, they have underlying chronic pain. That much we know. Okay. And that has very serious implications in terms of how we treat them. Traditionally, for sickle cell pain, we provide NSAIDs and opioids. Okay. That's the standard way we've been treating sickle cell pain. Okay. But at least over the last 10 years, we now begin to look at innovative ways. We now begin to look at different ways in which we could really begin to address sickle cell pain. So the future looks very, very optimistic. The state of sickle cell disease looks very, very optimistic. Okay. Why I say it looks very optimistic? For the last 20 years, there was only one FDA-approved drug for sickle cell disease, and that's hydroxyurea. Okay. But last year, we start seeing a lot of new drugs on the market. So some of you will be familiar with Voxeleto, like also known as oxybrita. And of course, Elevaco is another drug that was approved last year by the FDA. And then a third medication, Endari. Okay. So within a year, we have 3 drugs approved by the FDA, whereby for 20 years or so, we only had 1 drug. So this really is exciting time. Okay. But now, does anybody know why all of a sudden we have 3 different drugs on the market? Okay, I mean, that's a question I think, would be of interest, to the audience. And I'll tell you why. Again, Dr. Carla actually alluded to this fact that sickle cell disease is more than just a disease of the hemoglobin. It's more than just a disease of the red blood cell, clumping up. It's much more complicated than that. And you don't need to understand these, excuse me, you don't need to understand what this structure is all about. But what is important here is that when you're going through a sickle cell crisis, there's a lot of stuff happening, okay? And scientists have identified at least 8 different processes going on, okay? And that has very, very interesting clinical implication, and here's why, okay? If there are 8 different processes going on when you're having a pain crisis, then for you to reverse that pain crisis, it means that you need to have a medication that will address all of those processes that are going on, okay? If your medication is not addressing all of those processes that's going on, then you're not gonna get relief easily, okay? What we want to do, what we want to accomplish when somebody is having a pain crisis is to prevent, is to stop the blockage of those blood vessels. That's what we want to prevent. We want the blood, to flow, because if the blood is flowing freely, then you're not going to be in pain crisis. So our medication has to be such that they could actually prevent those blockages from happening. Okay, so that's a new idea that we're now beginning to learn about sickle cell disease, and that we need to find very interesting, very innovative ways, very smart ways to treat sickle cell pain. And fortunately, there is a field in medicine. It's a brand new field. It's really not brand new. It's been around for a good 50 years, but it was only in the last 20 years that it started having clinical application where we can actually use this field in clinical practice. And this field is called pharmacogenetics, okay? It's a fancy word, but what it means, is that we're combining pharmacology and genetics. We're using knowledge about how our genes work in the body. We're using knowledge about how the genes work in the body to determine which drug would work for the patient and which that drug would work. So that's what pharmacogenetics is all about. And I'm going to take time to just explain it to you. We now know that the one dose type of treatment regimen does not fit everybody. Folks, when you're in a crisis, you might get morphine or different opioids. But we've realized that you cannot prescribe the same dose for every individual because individuals are genetically different, okay, in terms of how they break down the drugs that we prescribe to them, okay? And pharmacogenetics has actually provided us with the lens that we could use to determine the different ways in which individuals metabolize the drugs that we prescribe when they're in pain crisis, okay? And we now know that certain individuals who have genes that will make them metabolize drugs at a very slow pace, okay? Like this individual here on the slide. And then we have some other individuals who, will metabolize drug at kind of like steady but not fast pace at all. And then we have individuals, who metabolize drug at a faster pace. And then we have individuals now who metabolize drug very, very fast. And so that's how our body handles the medication that we prescribe. So the usefulness of this information is that we can now identify our patient, as to whether they're a poor metabolizer, meaning that they metabolize the drug very slow, or intermediate metabolizer, meaning that they metabolize the drug, but at a kind of like steady pace, or it might be extensive metabolizer. And extensive metabolizer is really the way in which the average individual will metabolize or break down medication. And then you have some individuals who are ultra rapid metabolizer, meaning that they'll break the medication very fast. So any patient, take any group of patients, when you look at how their body metabolizes drug, they will fall into one of these 4 categories. Okay. Now you begin to see why this is important. Okay. See, you have a sickle cell patient who is in a pain crisis, and is now admitted in the ED, and we start drug infusions with morphine, okay? But if that individual is a poor metabolizer for morphine, then that individual is not going to get any relief at all. The pain is just going to, get worse, okay? So with this kind of information, we can now begin to, in a very smart way, manage how we prescribe and how we treat and how we dose medication for our sickle cell patients, okay? So what we really want to do is we want to test individuals. We want to take a blood sample and then see who is a poor metabolizer, see who is an extensive metabolizer, and so forth. Okay, and that information can now become part of their treatment plan. Okay. And so basically, this is how it works. So you might even want to ask, well, why are some people slow metabolizer and why are some people fast metabolizer? The logic is very simple. It's very simple. Just if you understand how sickle cell is inherited, then you understand, how this pharmacogenetic processes work. We know with sickle cell disease, you inherit 2 genes from your parent, okay, what we call the trait, okay. So every gene in your body, you actually inherit 2 copies from each parent. So individuals who are poor metabolizers, might inherit 2 genes that are not working at all, okay? Individuals who are intermediate metabolizer might inherit the 2 genes, that breaks down drug, but one of those genes might not be working at all. So only one is functional. Similar to what you refer to as having the trait. Okay? And then you have individuals who inherit two genes from the parent, and they're normal, so they can function effectively. And another interesting fact about the human body is that, yes, we do get 2 copies of genes from a parent, but there are cases when we actually get more than 2 copies. So there are some individuals who could have maybe 3, 4, 5 copies of a gene, and if the gene that they have 4 or 5 copies of is a gene that breaks down drugs, then it means that gene is going to work at a very faster rate. Okay, and the implication here is that an individual who has 3 or 4 genes, 3 or 4 copies of a particular gene, if you prescribe medication to that individual, then that individual is going to break down, is going to metabolize that gene at a very fast rate, such that they're not going to get any benefit from it. Okay. What this means then is that if you're going to prescribe medication, once you found out that different individuals, have different metabolic capacity, once you determine who is a slow metabolizer, who is a fast metabolizer, and so forth, then you now begin to titrate their pain medication. You now begin to titrate their pain dose. So for example, this individual is a slow metabolizer here. So this is usually the normal dose that you prescribe for somebody who has genes that works effectively. But with a poor metabolizer, you either give them a different medication or you give them a smaller dose. Okay. Now, if you move to the other extreme, an individual who has 3 or more copies of a gene that breaks down a particular drug, instead of giving that individual the normal dose, you might have to give that individual more to compensate for how fast the body breaks down medication. Okay, and then so the idea basically is an individual genetic profile determines how you titrate the dosage of the drug that you prescribe when they're in a pain crisis. Okay. So this is the future. This is the future of medication management for our patients. We're going to find who is a poor metabolizer. We're going to find who is an intermediate metabolizer, and who is an extensive, and who is an ultra rapid. And then we're going to treat them according to their genetic status. Okay. And so that's the kind of work that I do. You know, the patient that I work with, you know, take a blood sample. The test can be done in labs, in commercial labs all over the country. It's very much like those ancestry tests that you do, okay? And they're not really that expensive. So most of my research has been trying to determine how sickle cell patients metabolize drug based on their genetic profile. And we've done a number of studies with patients across the country, and they basically give you an idea, you know, of different. Here we have different. Different genes that are involved in drug metabolism, and here we have the number of individuals that we test that are extensive metabolizer, ultra rapid metabolizer, poor, and so forth. So this is a very rational way of really using science to improve patient management. So the future for pain management in sickle cell disease is very bright. You know, it's very bright. You know, and I am very optimistic that it's just a matter of time before you know, in our hospitals, in the healthcare, in the clinics, we can start incorporating pharmacogenetics into how we care for our patients. But I'm also very optimistic because I believe maybe five, if not earlier, 5 years from now, if not earlier, we kids today have newborns. We have newborn screening, okay, whereby we test kids to see if they have any genetic disorder, and sickle cell is one of those genetic conditions that are screened. Okay, the future for pharmacogenetics is that we can now test babies at birth to find their metabolic status, to find their metabolic genotype. And then we could actually start treating our kids, you know, at a very young and early age, and in a very rational way that would minimize the pain, you know, that kids usually experience, you know, from sickle cell crisis. So I guess what I'm trying to say here is that the future is rosy, and I am, you know, just happy to share, you know, this development in genetics to your audience, and that's the news I have for your audience.
Oh, wow. Thank you so much, Dr. Cheedy. We appreciate that. That's so encouraging to me, you know, as a mom of a sickle cell warrior, and that this is coming down the pike. And I know that Dr. Carla has helped us develop a plan for Braden for school purposes, for to consider that. And so when you mentioned about it being an individualized plan or treatment, I mean, that's even better, because now, like you said, rational, you use the word like a rational method of determining the pain medication, and not just, it's never one size fit all, and it's not simple, this condition. So yeah, this is very encouraging, and this is a lot of good, valuable, important information. So did I have a question? Angela, do you see any questions on social media for Dr. Cheedy?
Sorry, I have a comment. Hold on. It's from Miss Yvonne Donald. She stated that these advancements over the past few years are a blessing. Many predict oxybrita, approved last year, to be the game changer for fatigue in sickle cell patients. For so many years, we only had hydroxyurea. Thankful. Another person said, thank you for this information. It was very informative. And thank you for your research and all the work that you're doing. So we look forward to continuous advancement for sickle cell patients. I believe that's all we have.
All right. Dr. Cheedy, you want to respond to any of that?
Oh, well, basically what I want to go back to and emphasize is it was a comment I made earlier. And traditionally, we believe, that what caused sickle cell crisis was simply the blockage of the blood vessels. Okay? But the research over the last several years have shown that there's a lot more going on. And we've been able to identify some of those processes. Okay. So yes, we now have 3 brand new medication. Okay. But what's interesting though is that those new medication, each of them address some of those processes, but not all that are going on. Okay. So yes, they're welcome. Okay, but then individually, they're not going to be the game changer.
Right.
So what we need moving forward, is smart medication management. Smart medication management means that for pain crisis, we need to have or prescribe multiple drugs that will address all of those processes together. I mean, it could be 3 or 4 drugs that will address all those processes together, just to clear the blood vessels and allow the blood to flow. Okay, so we might need maybe 3 or 4 medications to do that. People might just need 2 medications that could do that. Maybe we just need a blockbuster medication that could do all of those, that will take care of all of those processes. Okay, we're not there yet. Okay. Right. But the good news is that with these 3 medications that are already on the market, they have started. We can now begin to address, those processes that are going on. Okay, there are other compounds, there are other medications that are in the process that are going through clinical trials right now. So I think like I mentioned, I'm a very optimistic person. The future is rosy. The future is rosy because now again we begin to understand what's going on. So it's just a matter of time for us, to begin. For us, for the pharmaceutical industry, to maybe find that one blockbuster drug that could do everything that is required to clear the blockages. Okay, or maybe just 2 could be good enough. But the good news is that we now have a better understanding of what's going on. And with that better understanding, we can now begin to take steps, to address, what's going on during the pain crisis.
Right. And I think you touched on it, as well as Dr. Carla touched on, pain in itself. Pain can trigger, well, we know that when pain is occurring and in a sickle cell warrior, they can be feeling some level of pain on a daily basis. And yes, it is chronic, but that pain can trigger you know damage is being done when there's pain, and it can trigger other things. It can cause stress, mental health issues. So being able to recognize the different layers of the problems to impact or take care of that pain, to prevent it, oh my gosh, that is a huge deal. That is a game changer, definitely. So it's encouraging. So we appreciate everything you shared tonight. So, and we want to just remember to tell everybody, even if you're watching this video on replay, if you have any questions of Dr. Cheedy or any questions of Dr. Carla, you can leave them in the comments, and we'll be sure to get your questions to them and get you an answer or response to your question or even your comment. We will relay those as well. We want to check one more time to see if there are any additional questions. Angela? She probably have to hit or mute.
No, ma'am. They're good.
They're good.
No more questions.
Okay, there was another comment. This is an incredible groundbreaking development for patients with sickle cell. Thank you, Dr. Cheedy. We don't have this in the UK. Do you think this will be introduced worldwide?
So what I've talked about, pharmacogenetics, is not new. Okay, this is in some part of the United States is actually standard of care for cancer patients. Okay. This smart way of medication management, has been around for a while. It's been used in for cancer treatment. It's been used to a large extent in psychiatry as well. What I have done, and some of my colleagues, is actually introduce this to sickle cell disease. But the concept of pharmacogenetics is applicable to any disease you could imagine. Because the idea basically is you just want to figure out how an individual breaks down or metabolize the drug that you prescribe. And then you use that information to titrate, to manage how you dose the medication. So it's in some areas, it's actually standard of care. And it is not unique. It's not unique to the United States. It's practiced in Europe, in Asia, but to the best of my knowledge, its use in sickle cell disease has been limited. It's still a work in progress.
Right. Well, we're glad to have you on our team. So
I'm glad to be on your team.
Yes, absolutely. So again, this has been so good. This has been so overwhelming. I think we hit the jackpot to have two advocates for sickle cell disease in the professional realm who have told us during this event that this is their passion. This is their purpose. So that is so meaningful to this mama of a sickle cell warrior. And I'm sure to so many who are listening, the warriors who are out there, to know that they have some advocacy. And I hope that, it catch on to the point where we can share this information through our hospital systems, other physicians who are treating other warriors throughout our state and definitely our country. So we're so excited and encouraged about this. So once again, Dr. Cheedy, I appreciate it. You guys, you can listen to this again. We want to thank Dr. Carla Roberts for taking time out of her busy schedule to speak with us and to share knowledge, to add to our series of discussions of topics that are important to those with sickle cell disease. And we want you guys to join us again on next Tuesday, where we will be talking about nutrition, which Dr. Carla did mention on that as well, because that's important piece of the puzzle as well. We have to make sure our warriors take care of the whole them. It's so important just to be able to manage this disease. So thank you, Dr. Cheedy, and thank you, everybody.
Thank you for having me on. Okay, goodbye.
Bye, everybody.